assembled here for this annual congress, annual conference of GI core group of IAPN India. So first of all, I like to thank the Kolkata chapter for giving me this opportunity to talk on this topic in the GI conference. So my topic is on the nutritional support of an acute pancreatitis. You know, the pancreatitis is a severe disease. If it is mild, no problem. If it is moderate, the problems are little. But if it is severe pancreatitis, then the problem is going to be huge for the patient. So if suppose, slides are not moving. So this, just to give you a hypothetical situation to know the severity of the acute severe pancreatitis. If anybody has this situation in your life, and if you want to escape with a choice, as an anesthesiologist and intensivist who know the severity of this pancreatitis, I like to choose among the options of cancer or the acute pancreatitis. I'll just go for cancer rather than the acute severe pancreatitis. So the morbidity and the mortality following the severe morbidity the patient undergoing is very high in acute severe pancreatitis. So to give you an overall impression about the severity and how we have to manage them, I like to take up this particular case for our discussion. He is a 54-year-old male, had acute calculus cholecystitis and biliary pancreatitis. He had underwent laparoscopic cholecystectomy in another hospital. He had worsening of pancreatitis over a week leading to necrosis. He is not an alcoholic, he is a teetotaler, he don't have any comorbids in the 54 years and only biliary pancreatitis he had. He is afebrile and no signs of sepsis but having some GI intolerance and decided to wait for the surgery. The surgery planned is here the necrosectomy of the pancreas. So here the nutritional assessment. So nutritional assessment is to detect the malnutrition in the severe acute pancreatitis. So when you take any of the tools and you just want to know the severity of the malnutrition in this acute pancreatitis, if you go by the SGA, this man is having a mild to moderate malnutrition because he don't have the comorbid, the illnesses, everything in the last 15 days. So the malnutrition score is less. Oral intake is only 500 to 750 kilocalories and the proteins is taking very minimal. Weight is 72 kg, height is 175, the BMI is 21 and his albumin is very low, 2.3 grams per deciliter and vitamin D is very low. And the CRP is very high, 136 and lipid profile is normal. So this is the rapid assessment of a patient and we all should remember one. The acute severe pancreatitis patient are vulnerable to develop malnutrition in the course of illnesses. To start with, in the initial stages, the inadequate intake, feed intolerance, GI intolerance, poor appetite, vomiting and pain are the main reasons for which they are going for a malnutrition. In the initial week, like our man, 54-year-old man, is having the problems of going for malnutrition because of these reasons. So we have to address the pain, we have to address the vomiting, and we have to improve the appetite on these individuals in the initial period of time, detecting the malnutrition and treating them. And the physiological changes which is going to happen because of the reduced gut absorption and the gut barrier dysfunction, exocrine insufficiency, this will lead to malnutrition on them. And as the disease progresses, metabolic derangements, catabolism, inflammation, sepsis, hyperglycemia will all lead to malnutrition on them. Complications of gastric outlet obstruction, gastroparesis, the fistulas which they are going to have, the paralytic ileus which they are going to face, everything will lead to malnutrition on them. And keeping in mind, detecting this type of malnutrition, we have to treat the acute severe pancreatitis patients. So we assess them with a subjective global assessment where it comes as a mild to moderate malnutrition, but this man has to undergo the surgery, and when you want to use another tool to assess the malnutrition in the perioperative nutrition, this is the one scoring system, preoperative nutrition score. Here the man comes into the severe malnutrition category. Look into that, the BMI is good for him. Weight loss score is not much for him for the last 6 months. When these things are not there for him, he comes to the malnutrition status because of the step 3, intake score. Have you been eating less than 50% of your normal diet in the preceding week? This man comes into this malnutrition to undergo the surgical procedure. If the answer is yes, then check the albumin level. He has a low albumin and he also low vitamin D. With all put together, our assessment of detecting him as a malnourished patient to undergo a surgical procedure is little different. He becomes severe malnourished rather than mild to moderate with SGA scoring system. So now we have to put him to the pre-operative nutritional preparation, because we all know malnutrition is a modifiable risk factor for surgery. If you modify this malnutrition, the prognosis, the complications lesser, everything we are going to have in this acute severe pancreatitis patient. So that is called prehabilitation. Taking them in a good nutritional status for a surgical procedure is a prehabilitation. Once you schedule him for the surgery, the PONS score is positive, then pre-operatively we have to give them the high protein diet with the HMB fortified oral nutrition supplementation for at least 4 weeks before taking them for a surgery. The perioperatively carbohydrate preloading has to be must, and immunonutrition for at least a week before taking him for a surgery. Post-operatively, the immunonutrition has to be continued for 7 days, and the same high protein diet has to be continued for 4 weeks. So 4 weeks pre-operative preparation and 4 weeks after the surgical preparation. This is the norm we have to follow whenever you are taking a surgical patient for a surgery before making them nutritionally all right. Even if the PONS is negative, they are not having a malnutrition. Remember, the low nutritional risk pathway is also having a nutritional preparation. The immunonutrition for 7 days pre-operatively and carbohydrate loading 2 hours before is very, very important. So whether they are malnourished or not, for a surgical patient, this amount of preparation is required to avoid the complications. And coming back to our patient, do you have a time to do all these things? Because you have a pancreas necrosed and he has to undergo the pancreatic necrosectomy. Now it is not infected, we are waiting. Once he becomes infected with the signs of fever, signs of infection, fever and tachycardia and SIRS, then we have to be in a hurry to take him for a procedure. So there comes a new nomenclature. Instead of prehabilitation, it's called cohabilitation. Being an anesthesiologist, before taking a cesarean section patient, if it is elective, before giving a spinal anesthesia, presuming that spinal anesthesia can cause hypotension on them, we used to preload them with 1 liter of crystalloids before giving the spinal. That is called preloading crystalloids. If suppose the patient comes for an emergency cesarean section, we don't have any time to preload the patient. So what we'll do is, we co-load them. We put the spinal and then give the 1 liter, rushing it immediately to them. So this is called co-loading. So similarly, in a prehabilitation individuals where you have a time, you can wait for 4 weeks and prepare them and take them for a surgical procedure. But when you don't have the time, suddenly crashes and this patient become an emergency patient, then we'll go for a cohabilitation, where at least whatever the time possible, try to address the immunonutrients to them, try to address the high protein diet to them, so that the cohabilitation of a nutritional preparation is very important in situations like this, whether it is enteral or the parenteral. In a preloading, crystalloids and colloid controversy is always there in anesthesia. Like that, when you are rehabilitating a patient, whether to rehabilitate orally or the parenterally, even though it is debate, the ultimate aim of our is to give them the adequate nutritional support before taking them for a surgical procedure. And this man, no time, and he had underwent a pancreasectomy. And the tubings is very important. During the surgical procedure, we have to know the availability of the tubes to feed them. So the surgeon has to help us to put the tube for the patient to get an enteral feeding. And this is the timeline of this patient. And this patient had very complications in the 16 days. In the first 25 days, he had all the problems. And he had underwent a loop colostomy, loop ileostomy, to avoid the colonic complications in acute pancreatitis. So the implications of this loop ileostomy, to avoid the colonic complications, we have a problems in addressing the nutritional needs. And the epidural analgesia in acute severe pancreatitis patient, by nullifying the pain, by avoiding the opioids, so opioid-induced vomiting, we can allow them to have a good enteral feeding. So always insist thoracic epidural analgesia in acute severe pancreatitis patient to feed them well enterally. And this is the loop ileostomy. Just to give a narration what the problems he had in the course of time, he had a lap cholecystectomy, he had a pancreatic necrosectomy. After the necrosectomy, he had the loop ileostomy, and the feeding jejunostomy is there in the jejunum. And later on, he developed a pseudo obstruction. It's a functional obstruction at the level of the third part of the duodenum, where the patient continues to have a nasogastric tube draining 1.5 to 2 liters of bile every day. When you put a scope, the scope is easily passing in. But when the patient starts taking orally, he is developing a retention, gastroparesis, and the reversal, it is coming through the nasogastric tube, 1.5 to 2 liters. And this bile, we don't want to replace it parenterally. Take the bile and transfuse this bile. This man had 1.5 liters through the rice tube, and from the rice tube we will take it and put it back through the feeding jejunostomy tube. The bile is rotated, re-infused again. So there are pumps available, the same pumps like a rice tube feeding, you can give it in the feeding jejunostomy, take the bile and with the pump we can pump it, or intermittently we can push it down, so the bile is not wasted. So the enteral route we have to utilize to the maximum and try to decrease the output of the fistula by taking measures in a short bowel patients, the similar measures by giving them the H2 blockers, proton pump inhibitors, anti-diarrheal drugs, and oral rehydration solutions. Everything you can try to decrease the jejunal ileostomy output and to decrease the backflow of the fluids. So everything you can measure, every measures you can take just to give the feeding in acute severe pancreatitis patient through the oral route, through the enteral route, not to go and depend on the parenteral route, supplementing them. Tube damages are more common in such a long period of feeding them. FJ tube, if it is get blocked or damaged, you have one another tube called trilaminar tube, and the trilaminar tube have a 3 lumens, but one tube through the nose, like a rice tube it go, the tip will be in the jejunum, and the jejunum you can feed, and in the gastric lumen you can aspirate. So this tube has helped this particular gentleman very well. With a one single tube, we used to have a gastric drainage 1.5 liters, take it and then push it back in the same tube to the jejunum. So this type of tubes are available. As a clinical nutritionist, we all should know the types of tubes available. Remember, the fall of the pancreatic rest concept is there. So there is no rest to pancreas in pancreatitis patient. We have to feed them orally. The important points in the nutritional support of the pancreatitis: early enteral feeding. Semi-elemental feeds only rarely used. Nasogastric is not inferior. Jejunal feeds if is feasible. Feeding jejunostomy during laparotomy is must. Parenteral nutrition in caloric deficit patient after 5 days. Supplementary parenteral nutrition should be addressed if you are not able to give them the adequate oral nutritional support. Fat emulsions are not contraindicated. Olive oil based fat emulsions is preferred. Watch for hypertriglyceridemia in parental nutrition. Immunonutrition with glutamine and omega-3 fatty acids are really helpful in acute pancreatitis patient. And coming to the rehabilitation. Once they come out of all these illnesses after 60 days or 70 days, we have to rehabilitate them. We have to give them the adequate lean body mass to these individuals. So you can use the anabolic steroids. You can give them the beta blockade drugs like propranolol, and you can give them the high protein diet and ask them to do regular exercises. So the exercises, anabolic steroids, high protein diets, everything put together, we can build up their lean body mass so that they have a good quality of life and they can prepare themselves for the next surgeries. So this is how we have to rehabilitate acute severe pancreatitis patients. So the deduction is very important, and after deducting it, try to use the enteral route to the maximum in acute severe pancreatitis patient. Don't jump straight to the parenteral nutritional support, and adequately rehabilitate them for them to have a good quality of life after their illness. Thank you so much.